Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Peace, YouTube. I'm your moderator and narrator, Uriel Riley. So, we pick up in the 24th chapter, page 375. At the top. All right. It's time for the peace. Just breathe it in. Welcome. Peace, YouTube. The top of page 375. Happy Monday. Airway monitoring. The minimum requirement is to monitor the degree of PEEP being applied. Simply applying a PEEP device is not adequate. There must exist a manometer within the system that reflects the existing airway pressures. The closer the manometer is to the patient's airway, the more reliable the measurements. In addition to monitoring PEEP levels, this manometer may be used to help reflect compliance changes of the system. All right. Moving in. Right. Here we go. Effective static compliance. Compliance is an important concept in the application of PEEP therapy. A simple method of grossly reflecting changes in pulmonary compliance would be an obviously desirable clinical tool. When appropriately measured and interpreted, the effective static compliance (ESC) measurement is such a tool. Figure 24.5 illustrates a typical tracing of a positive pressure inspiration with an inspiratory pause. The peak pressure is the result of the system's impedance to flow. See Chapter 3. This impedance includes both compliance and resistance factors within the pulmonary system and breathing circuit. If expiration is delayed for a period following delivery of the inspiratory volume, a significant portion of gas in the upper airways will be distributed toward the alveolar level. See time constants, Chapter 3, and it's and inspiratory pause, Chapter 23. Here we go. 24.5 down at the bottom. This is figure 24.5. Peace. Highest heart love. Welcome, YouTube. Positive pressure ventilation with an inspiratory pause. The lightly shaded area represents the pressure change related to resistance phenomena. R equals resistance, and delta P equals pressure change. F equals flow. The darkly shaded area represents the pressure change related to compliance factors. C equals compliance, and delta V equals change in volume. Here we go. 24.5. We are almost complete with this chapter. See? Beautiful. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, 1979, second edition. Here we go. All right. The rapidly diminishing trans airway pressure gradient results in rapidity diminishing flows. Since the pressure resulting from resistance factors is flow related, as flow significantly decreases, the pressure related to resistance will significantly decrease. Yes. It is reasonable to assume that the pressure change represented between the inspiratory plateau and peak pressure in figure 24.5 is attributable to resistance factors. Thus, the pressure differential between inspiratory plateau and baseline is essentially attributable to compliance factors. Compliance, C equals delta V over delta P, is a static measurement, i.e., it can only be measured in the absence of flow. However, a reasonable estimate of the system compliance can be calculated by dividing the exhaled tidal volume, delta V, by the pressure differential between baseline and inspiratory plateau. This measurement is termed the effective static compliance to denote that although flow is greatly diminished, it is not entirely absent. Peace, YouTube. Woo, I know it's a lot. We are running into this 24th chapter and completing it here. So thank you so much for being with us and reading with us. We're at uh, top middle of page 376. All right, principles of PEEP therapy. To avoid confusion, it is necessary to explain the term effective dynamic compliance, EDC. Historically, initial clinical attempts to estimate system compliance utilized the baseline to peak pressure as delta P. Obviously, this was misleading, especially if significant resistance factors were present, even though it was later understood that EDC was to be measured with inspiratory plateau pressures. Many clinicians were confused and various texts were unclear. The term EDC should be relegated to history and the confusion avoided. Inspired oxygen concentration, FiO2. Appropriate monitoring of ventilation perfusion relationships demands accurate measurements of FiO2. In addition, optimizing arterial oxygenation while minimizing FiO2 is a prime goal of PEEP therapy. The respiratory care practitioner must assure accurate and frequent measurement of inspired oxygen concentrations. Mass spectrometry, spectrometry. Yeah. This technology promises the clinical ability to accurately monitor all airway gases, including trace amounts of inert gases, in combination with flow measurement. When combined with recent computer technology, the mass spectrometer becomes a non invasive bedside monitor of the critically ill patient with exciting potential. For example, it is possible that oxygen consumption, compliance, and resistance may be routine bedside measurements in the near future. Even more exciting is the probability that routine FRC measurements will be available. It appears that the ideal PEEP monitor may well be the serial FRC measurement. And we know we have these now, right? I know that's why I love reading books and history. We get to see how things came about in their correct context. That's why, I started off on this channel reading in the history book, anthropology, and now look, we went through what was it? The health books about poverty, ethnic identity, and healthcare. We read, that entire book was big, right? We got to see how the beginnings of healthcare and privatized healthcare as well. And so that's why I like going back and reading these because we're in medical and health field right now. We get to see how we have made advances. And it's something to be honored, right? It's something to say for that. We've had so much progression. So thank you for reading these books with us, all those in the replays. I will put in the description the vocabulary. Okay? Hemodynamic monitoring. Circulation of blood is an essential prerequisite for tissue oxygenation. Measurements reflecting blood circulation are termed hemodynamics, which is discussed in depth in chapters 26 and 27. Hemodynamic monitoring in some form is indicated when PEEP therapy is instituted. Minimal hemodynamic monitoring includes measurements of arterial blood pressure and pulse, and the clinical estimation of peripheral perfusion, none of which require invasive measures. In some cases, a central venous pressure measurement may suffice, although the most satisfactory technique of invasive hemodynamic monitoring is the pulmonary artery catheter, which allows ventricular preload and afterload measurement as well as actual cardiac output measurement. These are all discussed and in section 7. Oxygenation monitoring. Since a major clinical goal of PEEP therapy is to improve arterial oxygenation, serial measurement of arterial blood gases is a requisite. In most circumstances, placement of an indwelling arterial catheter is appropriate. Pulmonary artery blood gases, see chapter 28, are valuable in that serial measurement of arterial venous oxygen content differences, AVO2, reflects the adequacy of cardiac output in relation to oxygen consumption. Mixed venous oxygen tension, PVO2, is helpful in estimating the adequacy of tissue oxygenation. Serial calculation of an intrapulmonary shunt, QS over QT, is of great aid in monitoring PEEP therapy. Thank you so much for the likes and subs. Welcome to the peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer, Uriel Riley. So thank you so much for being here and reading with us. Wherever you're joining from, thank you so much. Hi, it's Heart. All right. Summary. The need for some form of airway, hemodynamic, and oxygenation monitoring during PEEP therapy is beyond question. The degree and sophistication of monitoring techniques will vary from patient to patient. Baseline measurements are always necessary since it is the physiologic changes resulting from PEEP that are paramount. As a general rule, we do not increase or decrease PEEP in increments greater than 5 centimeters H2O and repeat all measurements within 15 minutes of any change. Development of a flowchart in which the necessary information is shown sequentially in is invaluable. Right, here we go. Top of page 378. Airway suctioning and PEEP therapy. The arterial oxygen tensions are in excess of 200 millimeters Hg. Airway suctioning may result in PO2 decreases greater than 100 millimeters Hg. This has been widely interpreted as meaning that PEEP must be maintained during suctioning, a technique that is cumbersome, expensive, and time consuming. When airway suctioning is properly accomplished, as described in Chapter 16, it is our experience that arterial oxygenation does not fall below the maintenance level, even though PEEP is transitly discontinued. Thus, we have found it clinically necessary to change our routine suctioning technique for patients on 30 centimeters H2O PEEP or less. Here we go. Last paragraph of this section 24. We done did it again. Oh, we're the champions of reading on YouTube. That's for real. Physiologic PEEP. Yes. Thank you. Thank you. A widely observed clinical phenomenon is the spontaneously breathing intubated patients often have gradually decreasing arterial PO2s despite consistent oxygen therapy and adequate bronchial hygiene. This oxygenation deficit is usually reversed when 3 to 5 centimeters H2O PEEP is applied. In our experience, this observation is valid primarily in patients with pre-existing chronic pulmonary disease or neuromuscular deficits. Pulmonary physiologists have hypothesized the existence of a glottic mechanism that plays a role in maintaining normal FRC. This mechanism does not appear to be a simple resistance factor at the glottic level, but more likely an indirect effect on small airway caliber. In any case, this has been a proposed explanation for decreased FRCs in intubated patients. The glottic mechanism hypothesis seems to have been combined with the above documented findings and has resulted in a concept known as physiologic PEEP. In essence, this concept states that 5 centimeters H2O PEEP in the intubated patient will replace the glottic mechanism and help to maintain a normal FRC. It should be emphasized that there are no conclusive data available upon which any definite statements may be based. One recent study in postoperative patients showed no effect of 5 centimeters H2O on FRC. Other studies indicate the opposite. Ding! See, they were just beginning to find out. Wow. Wow. I love history. I love reading. In our opinion, that routine use of physiologic PEEP is unwarranted. It is very expensive to set up PEEP systems on every intubated patient when the benefits are questionable. On the other hand, we believe selective use of physiologic PEEP is justified. Our present criteria for applying physiologic PEEP to spontaneously breathing intubated patients apply to 1. Those who have demonstrated a drop in PO2 attributable to the removal of 5 centimeters H2O PEEP. 2. Those with significant pre-existing chronic lung disease. And 3. Those on augmented modes of ventilation at rates of less than 4 per minute. Physiologic PEEP in conjunction with augmented ventilation should not be considered significant PEEP therapy. Seldom are PEEP levels of 5 centimeters H2O or less critical to the supportive therapy of adults. It is perfectly appropriate to extubate from 5 centimeters to H2O PEEP. We did it. Completion of chapter 24. Yes. Going into chapter 25 next. Thank you so much for reading with us. We did it. We did it. Completion of another chapter. Let's see how it looks. Here's how it looks. La 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 la. We did it again. Much love, much love. Thank you for reading with us. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, second edition. Peace, YouTube. Thank you for the likes. Peace to all my friends and family, people, all the members and subs. We're pushing towards 600 subs on this peaceful part of YouTube where we read books and learn from masters. Shaking it up. Definitely, right? Shaking it up on YouTube, reading books, high level books too. I will put the vocabulary in the description and we will reconvene going into chapter 25. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Did it again. Another chapter. Peace, peace, y'all. I wish y'all had a wonderful day. Happy Monday. Happy new moon. Moving through. I love you. You know I love you. Thank you so much. Here's a glass of love water. Love to all the light workers, all my friends and family. Love to the great Lorianne Speed playing the piano tonight. She's writing some new music as well, and it's a celebration of her 1 year anniversary of releasing somewhere in time. So make sure you go check out that new video. We always promote the light workers on here. If you know of any other magical light workers and want to throw them in the chat anytime, always welcome. Hi, it's Heart Love. All right, here we go. Glass of love water. Mm. I love you. 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 I wish you have a wonderful evening. We are going to the soft green. Right? Going to the soft green cloud tonight. More rest and healing. We'll be doing different healing modalities on one another, mainly guarding and protecting and clearing out anything left in the A or heart energy center, heart chakra. That light green, keeping the heart light, releasing any doubt, any stress, any worries, right? So I'll see you there in the light green. You know it. Thank you so much for reading with us. Peace, everyone. Hi, it's Heart Love. I love you. I love you. You know it. Because I love myself. I love us. Thank you. Gratitude and high. I will see you soon. Peace, peace.